know me, I've been around here for over 30 years. I'm director of cardiology at the Children's Hospital. We now have a group of 7 pediatric cardiologists and 2 pediatric cardiovascular surgeons. And our specialty, pediatric cardiology, is relatively recent. It developed in the second half of the 1900s in earnest and has provided us with a mean of repairing congenital heart disease, most of the time definitively, sometimes temporarily. And so pediatric cardiology tends to these almost 1% of infants that are born with congenital heart disease. So we've been working at those for all these years, and now, of course, having been successful, they have grown up to adults. And so in the last several years, adult congenital heart disease clinics have been opening around the country, and we did that a couple of years ago in preparation to have ourselves be joined by a pediatric cardiologist specializing in adult congenital heart disease, because these adults, they go to the adult cardiologist, and the adult cardiologist feels uncomfortable because this is not coronary heart disease, and they may have only one ventricle, or they may not have a pulmonary artery, and they sort of are lost in the complex pathologies that they are receiving. We pediatric cardiologists also feel uncomfortable when this 40-year-old comes with a history of Tetralogy of Fallot and high cholesterol or hypertension or adult kind of pathologies. So a new specialty has been born, and actually 2 years ago, the first board examination for adult congenital heart disease was taken. And we saw the need to hire somebody to be joined by somebody specializing. So it is with great pleasure that I'm going to introduce David Briston, who is a pediatric cardiologist specializing in adults with congenital heart disease. David?
Thank you. Thank you, Dr. Ramos. Thanks. All right. Good morning, everybody. Before I start, I'd just like to say thank you for the organizers for having me here, and of course to all of my colleagues, and those who I've met and those who I've yet to meet. Today, I want to go over an important topic to me, as Dr. Ramos introduced. And I entitled this talk, Congenital Heart Disease, Not Just a Kid's Problem. I don't have any disclosures. I wish I did, but I don't. So who I am, he told you a little about this already. I did internal medicine and pediatrics at the University of Miami, so for any med-peds people here. And then I did pediatric cardiology in New York at Albert Einstein College of Medicine, or in Montefiore Medical Center. And then most recently, I went on and did adult congenital heart disease at Nationwide Children's and Ohio State University. And I love putting the pictures in here. If any of you football fans, there's Brutus, of course, who is a legend in Ohio, if you're not from there. And of course, the University of Miami. The Fighting Maccabees of Yeshiva University did not make this slide. So I'd like to sort of frame what I'm going to discuss today in the context of a case, which I'll hit on throughout this talk. I'll use the case of a young woman who was born with Tetralogy of Fallot, who underwent a surgical repair as an infant without complications, but she hasn't been to a cardiologist in decades. And now we get a report, she's coming in to see us for the first time, of mildly dysfunctional RV, a normal LV, but she's got free pulmonary insufficiency and an enlarged RV. And so how we care for this patient will be something that hopefully we can learn together as we go forward. So the objectives for today's talk will be to define what ACHD is, understand its epidemiology, which is way trickier than you might imagine, understanding the new guidelines that were just published in August of this year. These are an update on the 2008 guidelines, and understand indications for a pulmonary valve replacement in Tetralogy of Fallot, which is a relatively common lesion, and then also understand what's available to us here at Florida Hospital. So a few facts. ACHD, or adult congenital heart disease. It's a field of medicine dedicated to adults who were born with congenital heart disease, obviously. But there's actually now more adults than children. We don't get this data, however, from the United States. We don't have a good enough tracking mechanism with our multi-payer system in different states to be able to do this. We get most of our data actually from Canadian studies and then take the Canadian data and apply it to the American population. They have unique medical identifying numbers, which makes it very easy no matter what hospital somebody goes to, so long as they stay in Canada, that they can be tracked. Because this is now such a big deal and there's so many patients, it's actually become an official subspecialty, as Dr. Ramos was mentioning to you. And so if any of you guys want to become an adult congenital heart disease specialist, I would tell you it's the best job ever. So for all the students and anyone in the back, you can change careers or do whatever you want to do. I highly recommend it. There are multiple ways to do it. The two most common ways are the training pathway, which is what I did, going through multiple fellowships after doing residency. I think it's a very comprehensive way to learn. But we also have to take into effect there are people who have been doing this even if they didn't have a title. And so in the initial certification in 2015, last year's in 2017, and next year's in 2019, you could be grandfathered in, so long as you were doing at least 40% adult congenital, or if you've kind of ascended into a more administrative role, if a quarter of your time was spent involved in a program as opposed to necessarily seeing patients, that also was considered an acceptable way to become an ACHD cardiologist. There are actually other pathways. I'm not going to focus on them. It's not commonly used that a research pathway can lead to becoming an ACHD cardiologist, but that is another option as well. So this is one of the most important slides that I'm going to show you today. There is a lot going on. So I'm going to start by looking at the y-axis on the left, which is number of patients referred to ACHD centers. And you can see that there's a line, and then all of a sudden there's a change point. And this happened about a year or so after Canadian guidelines were presented in the mid-1990s. So you can see that the number of referrals they were getting, or the patient population that was being followed, was going up by a little over 1% per year. Then, after the guidelines were presented, but before they were actually even published, there was this inflection point, and it went up, and they started to go up by 7.5% per year. And so this is this led to a significant change in the number of patients who are there. And so you can see this with the red arrow. Now, I'll draw your attention to the other side. On the right, we see a separate axis, and this is the number of deaths per 1,000 ACHD patients per year. And so this has to do with the line that's underneath, the light gray line. And you see that this also was going up. I find this completely horrifying that in the 1990s, there were more deaths per year than there were referrals to congenital cardiologists. That's scary. Now, you see that the inflection point here actually happens a couple of years after the guidelines were published. So whether it was referrals going to physicians who are trained in taking care of these patients and then taking a couple of years of getting these patients in to then affect the mortality rate, I personally think that that's the case, or whether or not it's the guidelines actually being presented and people trying to follow them by themselves, I don't actually know, but I know that there was a significant change, and the p-value here is 0.04, and this p-value has been used to justify my field going forward. So this, as I've mentioned before, is Canadian data, and we apply data like this to the United States. This is also from Montreal. This is aging among CHD patients. If you take a look at this graph, you'll see that the majority of patients in the 80s were dying under age 10. It was almost 4 out of 10. This is a huge number. The mortality rate was incredibly high before kids even got out of elementary school. And you see that a few patients did actually survive to be greater than 90 years old. This study did happen to include a few diagnoses that maybe aren't considered adult congenital heart disease in other realms or congenital heart disease, so there are some patients who make it older. But the main point is, of course, to see the shift. And as you can see on the right side of the screen, there are now more patients surviving to adulthood, and the majority of them are happening because they're not dying under age 10. In this study, it's fewer than 10% are dying before age 10. And so the mortality data are shifting towards older age. What does this lead to? To anybody who's been in Ginsberg Tower, we're seeing patients, I've been here 6 weeks, and I've seen at least a dozen patients admitted with congenital heart disease, and they're not only admitted because they have congenital heart disease. They're admitted, one had gout, one had hypertensive urgency, which may or may not have been related to their underlying congenital heart disease, but it's an extra layer of complexity that's added to these patients. This is a slide that I particularly like. It was first presented at AHA conference in November of 2015, and it was put out in circulation later that year, and then another version of it was published more recently. But I like this because it uses a variable called the standardized mortality ratio, or SMR, which gives you an idea of one population's mortality rate as compared to the general population. So if your standardized mortality ratio is greater than 1, you have an increased chance of dying based on the variable that distinguishes you from the general population, and vice versa if it's less than 1. So you see that all of the congenital heart defects listed here have an increased standardized mortality ratio as compared to the general population. Some of them don't achieve significance because it crosses the threshold of 1. But if you follow the trend, and it's not absolutely perfect, but the trend is from the top to the bottom is going from generally less complicated congenital heart disease to generally more complicated heart disease with single ventricle physiology and Eisenmenger syndrome on the bottom and something like VSDs and I'm presuming isolated aortic valve disease on the top. And this is something that we always kind of thought. I think that people have always said, well, it makes sense. If you have more complicated disease, you would have an increased mortality rate. But these were the first people to comprehensively and in a large scale be able to do this. And they did this in Spain, actually, using mortality data registry, which is very good, similar to Canada's level of data. So really to pound this point home, this is one of my absolute favorite pictures because it makes sense to me of we all take care of patients who are older at some point. And so 40-year-old people, what is the mortality rate of a 40-year-old? Which is scary as somebody who's quickly approaching there. But this says, look at these lesions here and imagine that they were 40-year-old people. So a 40-year-old patient who had a Fontan at the top, or a 40-year-old patient who has an isolated ASD or an isolated VSD. So a 40-year-old patient with an ASD has the mortality rate of maybe a 41 or 42-year-old person in the general population over the next 5 years. And so the idea is kind of give you an idea, sort of a midlife point, on what the mortality rate is and how damning are these diagnoses. And so you see that sort of our milder diseases like ASD, VSD, and sort of isolated valve disease don't significantly affect it, at least at midlife, whereas those that are more significant later on certainly do. So that single ventricle physiology patients, according to this study, have a 5-year mortality rate when they are 40, equivalent to a 75-year-old in the general population. So it's a different way to frame the same context, or same question. All right, so I'm going to shift gears a little bit and say, who are CHD patients? Does anybody know who this is? Anybody watching Miss America a few weeks ago? All right, well, I am a proud WVU alum, and this is Miss West Virginia. She actually works here in Orlando for Disney. Her name is Madeline, I'm blanking on her last name now, I think it's Collins, and she's Miss West Virginia. She also is a patient with Tetralogy of Fallot. She was quite nervous there were lots of interviews given about having a sternotomy. She had recently had a PVR, and she was very self-conscious about her sternotomy and how it was going to heal for the competition. Sadly, she didn't make the top 10, but my wife made me turn it off, so I don't know anything more than that. All right, this one you guys might recognize more. Maybe some of the younger people in the crowd will know. Who's that? Shaun White, right? He's a U.S. Olympian, skateboarder, all-around bro. He is also a Tetralogy of Fallot patient. I actually don't know if he has had a pulmonary valve replacement or not. I don't know. He doesn't have to disclose his medical history to me. So, but certainly a successful person. And who's this? The Governator, right? I guess there was a big scandal in the 90s. I didn't know about it. I was too young to know, but I guess he has a bicuspid aortic valve and he tried to have a Ross procedure and not tell his wife. I guess this was a big scandal. My mother told me about it. I didn't know. but he is a Ross patient, which meaning that his pulmonary valve was put in the place of his bicuspid aortic valve, and then he had an allograft, I believe, placed from his RV to his pulmonary artery. And he recently tried to get a transcatheter pulmonary valve replacement, I think it was a year or two ago, and I know that he ended up having to go to open surgery, and that was pretty recent. I'm not exactly sure if it was 2017 or 2018. All right, football fans, who's that? Teddy Bruschi, any Patriots fans in here? All right, one, okay. All right, well, so apparently he has an ASD. I don't know if it was fixed. I don't know if he had surgery. I don't know if he had a transcatheter approach to have this done, but he's a Super Bowl winning defensive, I believe he was a linebacker. And who's this? Any ladies here know who this is? A few smiles. Brett Michael, yeah, Poison. So I was jokingly going over this last night with my wife, and I said, look at all the successful things adult congenital patients could be. There's, you know, somebody who almost was Miss America, a United States Olympian, a governor, and considered the strongest man in the world, an NFL Super Bowl winning quarterback, and Brett Michael. But I think it does, I want to try and defeat the stereotype that these patients are debilitated or there's something wrong with them or they can't fend for themselves or they can't be successful. It's not true, right? And I hope that you always keep this in the back of your mind. All right, and so as I alluded to earlier in the talk, what is the actual prevalence of congenital heart disease? And so, as I think Dr. Ramos said, it's just about, just under 1%, or about 0.8% of live births. And depending on which data you want to use, some say the survival rate's greater than 90%, some say it's greater than 85%, but it's certainly high. And that's what's led to this changing dynamic. I will concede that it depends how you define congenital heart disease. So if you say anomalous coronary arteries, these are very common. If that's considered congenital heart disease, that certainly makes our numbers go up quite a bit. Aortic arch abnormalities, I don't mean a right arch, but I mean a double aortic arch or somebody with an aberrant right subclavian coming off of the descending thoracic aorta. That certainly counts as well. And then bicuspid valves, ASDs, and VSDs are the most common lesions. And to give you an idea that we really just don't know exactly what we're dealing with, there was a study done among patients who underwent coronary CTs, and they said that anomalous coronaries were present in 2.3% of the population. There's obviously some bias here, because I hope none of us here are just routinely getting coronary CT scans, right? It implies that there is at least something a little different about this population. There was a weighted meta-analysis done that said that it was much lower, about 1/3 of that at 0.7%. But that's certainly higher than I would have anticipated. Anomalous right subclavians off the descending thoracic aorta, there's a study put out last year that said it was 1.2%. That's pretty high, greater than 1% of the population. And then bicuspid aortic valves, this is, if you want to get disparate data, this is a good one to look at. When I was in medical school, I remember learning that it was 2.6%. And that 2.6% of the population, or 1 in 40, has bicuspid aortic valve, which I always thought was a little high. The guidelines that I'm going to go over shortly, when it uses all of its weighting and such, they say 0.46%. So that's probably a little closer, but I don't truly know what the epidemiology is, and could there be a difference between Spain and Canada's data and the United States, or definitely a different makeup. I want to apologize to my boss in advance from Ohio. His name is Dr. Daniels. He's involved in writing the guidelines. He always has a slide of a tidal wave destroying a city in reference to adult congenital heart disease, and I tried to come up with my own. I tried to make one that was pretty, but I just ripped this off of the internet. And I think it's a really good slide, though, because it really makes you think about how big the problem is and maybe how scared you should be if you want to look at it that way, or the need to get ready if that's another way of looking at it. But there's 1.5 to 2 million people in the United States who have adult congenital heart disease, and just really think how many that is. I mean, that's 0.6 to 0.8% of our population, roughly. All right, so a big problem is attrition. So there are these millions of adults that have congenital heart disease, but there's a study that suggests that under 40% of them actually see a cardiologist. But what's interesting is that the loss tends to be early, right? This is age 18. That's astounding. This, again, is a Canadian study saying that 39% of people born with congenital heart disease are still seeing a congenital cardiologist when they're 18. That's incredibly low, in my opinion. I think that is certainly something that needs to be changed, and it's certainly something that we need to address. And I would draw your attention also to the fact that 90% of these patients are actually interacting with the healthcare system. So they're going to urgent care, they're going to the ERs, they're going to their primary care doctors, they're going to see everybody out there, but they're not making it back in. And again, I don't need to see everybody every 6 months or anything like that, but the idea that these patients don't know that they should be followed by a cardiologist, they can't identify somebody to care for them, I think is a big deal. And it's an area that we need to strive to do better on. All right, shifting gears, going over the guidelines. These just came out in mid-August of this year. The two senior writers on the writing committee were Karen Stout and Kurt Daniels, and then they had a large number of people giving insight, adult cardiologists, pediatric cardiologists, and surgeons alike. It was endorsed by AHA, ACC, ATS, and 4 other major societies. And this was sort of an update on the 2008 guidelines. It attempts to codify or categorize patients by both anatomy and physiology. It does so by creating this new system, the ACHD Anatomic and Physiologic Classification System. They want it to be called the ACHD-AP. I don't think it's quite as sleek as the people who came up with it think it is, but it does a good job. And it tries to incorporate aspects of these patients' life, and it addresses, transition of care, access to care, and multiple other issues. So, specifics. It comes up with both a letter and a number, and the nomenclature basically is using a Roman numeral letter to refer to the anatomy and a letter to refer to physiology. And this is an attempt to try and get prognostic information and to convey that complexity doesn't always go with how you're doing. I have seen in my past a person who is a single ventricle who worked an 8-hour job in a factory and then maintained a 20-acre farm at home at night. And his VO2 max, when we put him on a treadmill, was over 50. Just to be clear, if you're not sure where that is, on the best day of my life, I'm getting a 33 or 35, right? And this guy had multiple issues, and he could do that. But there are people who have simpler forms of disease, isolated valve disease or an ASD or something like this, who can't achieve half of that. And so there's an attempt to try to separate not just what you were born with, but kind of what you're doing with it at that point in time. And the idea is that this can foretell the future with progression of disease. So starting with the anatomy, the Roman numeral 1, native valve disease, so isolated small ASDs and VSDs and mild isolated pulmonic stenosis is considered simple disease, as well as people who have had a PDA closed or a repair of an ASD or a VSD without any problems afterwards, without any sequelae, as we would say. This is considered simple, and these are the only ones that show up under simple. And to juxtapose that, I'm not going to go over this entire list, is number 2, moderate complex disease. This is sort of a takeoff on the Bethesda guidelines, which came out in 2001 or 2, but it basically incorporates the vast majority of disease as we look here. Again, I'm not going to go over all of this, don't worry. And number 3, those that are greatly complex. And so these are our patients who are cyanotic, single ventricles, interrupted arches, transposition, truncus, people with all of these things that you read about that you don't often see, like crisscross hearts, heterotaxy syndrome, ventricular inversion, sort of the really complex things that even fool us, as well as things like mitral atresia and pulmonary atresia. And so these are the most complex. So everybody gets rated as a 1, a 2, or a 3 based on their anatomy, with the idea that mild disease is a 1 and greatly complex disease is a 3. Probably should have put these in Roman numerals, but I guess I skipped there. And so the other aspect of the new nomenclature is looking at physiology. And so most of us are going to be pretty familiar with the New York Heart Association functional class 1 through 4, and this is similar to that. I want to be clear about this, but it does take things a step further, because those who are A are very similar to New York Heart 1. They don't have limitations, they have normal capacity, no arrhythmias, no significant valve disease, and they're doing well, right? And that's very similar to New York Heart 1. When you get to B, I would say that people who have mild hemodynamic sequelae, so this includes mild aortic enlargement, which isn't something we always think of. If you have a dilated ascending aorta, this isn't usually something that I would say puts you into a higher functional class group, but in this instance, it does. People with mild valvar disease or trivial or residual small shunts, as well as arrhythmias that aren't requiring treatment. So people that, they could come in and tell you, I'm doing fine, doc. I'm doing absolutely okay. But then if you look and see that, you know, they actually have an aorta that's 3.7 centimeters, you say, actually, you already have moved up to a group B. It always gets a little trickier when you, kind of like New York Heart 3. I feel like when I was a medical student, I never knew if somebody was New York Heart 2 going into 3 or 3 going to 4. 3 was always the hardest one to know. And so here, C is sort of equivalent to that. But anybody with moderate or greater, so moderate, severe, or free regurgitation or moderate, severe stenoses show up in grade C at least. Those with moderate aortic enlargement, and I would also draw your attention to the idea that pulmonary hypertension is showing up in here. So those with pulmonary hypertension that's not considered severe, but any form of it, get into group C. And then D is sort of the sickest patients that we deal with, those with Eisenmenger syndrome, end organ dysfunction, hypoxemia, severe aortic enlargement. And this is very similar to New York Heart 4. These tend to be people who are more debilitated as compared to others. So again, least physiologic impairment is A, and most is D. So I'll give you some examples. Tell me what you guys think. So number 1, a young lady born with coarctation who underwent an uncomplicated surgical repair. I'm not telling you what type. I'm not giving you any of that stuff. She's normotensive, normal exercise capacity, normal aortic measurements, normal end organ function. What do you guys think she would be? A. And what goes with the A? What number? 1 for a coarctation? So the only things that will be in a 1 would be a small ASD, VSD, or mild PS. So she would be a 2A. What if this same lady, you do a better job getting history, you go in there, and you see that she tells you, I had an MRI last year, and my ascending aorta was large. I don't remember how big, but you find out it's 3.9. So what do you think that would make her? It would be a 2B. I'll be fair to you that I didn't say exactly what the cutoff is. So 3.5 is sort of the cutoff for aortic enlargement, where you go, that starts with mild enlargement, puts you automatically into group B. What about this same lady? Everything sounds pretty similar here, but now her aorta has gone up to 4.4 centimeters. So now she is a 2C, because if you're 4 above, that puts you into the moderate aortic enlargement. And actually the cutoff for severe is at 5. All right, and what about the lady I told you about on slide 3, way back in the beginning, this young lady with Tetralogy of Fallot who's coming to us, and she's got, her RV's a little down, it's a little big, and she's got free pulmonary insufficiency. What do you guys think she would be? 2C, right. So even if she comes in here and says, I feel great, I just ran a half marathon, I do yoga, I am, I eat right, she's still a 2C, okay, based on her valve disease. All right. So keeping in mind Tetralogy of Fallot, I would say that given that it's the most common cyanotic heart disease, it's something that patients and you guys as providers might actually see a little more. And there's more, relatively more. For congenital heart disease, it's a lot, but for people familiar with AFib or heart failure, there's very little data published. And we took these data, or the authors did, and made guidelines regarding timing of PVR, indications for ablation, and safe insertion of transcatheter PVRs as it relates to coronary arteries. And so I'll go over some of these guidelines with you, but not in painful detail. They suggest that cardiac MRI is useful to quantify ventricular size and function, both ventricles. We tend to care about the right as for the guidelines, but you need to make sure that the left ventricle is not dilating or getting weak. Looking at the pulmonary artery anatomy, because we know that they can be hypoplastic, as well as left heart abnormalities. If you have hardware in, you can't get an MRI. CT scans can be a good surrogate, but it doesn't give quite as much information specifically about valve regurgitation. Coronary artery compression testing is indicated before placing RV to PA conduits and doing stenting and transcatheter valve placement in patients with repaired Tetralogy of Fallot. That's a class 1. And then I'm going to briefly touch on arrhythmia here. There's programmed ventricular stimulation can be useful to risk stratify adults with Tetralogy of Fallot and additional risk factors. So what are those additional risk factors? They include LV systolic dysfunction or diastolic dysfunction. This came from a Paul Carey paper, again, Montreal group, where diastolic dysfunction was considered at 12, which is not this. I know sometimes with pH data we think of 15 as being diastolic dysfunction, but only 12 here. Having non-sustained VT, a wide QRS greater than 180, or extensive RV fibrosis on an MRI. And then I'll mention, of course, on the bottom here that cardiac catheterization with angiography can be indicated to assess hemodynamics. And some of the guidelines that we use actually use right heart cath data to be able to determine if a PVR is indicated. Another class 1 guideline here is that PVR is indicated for relief of symptoms. Now, a lot of people have more than one thing wrong. I don't know if any of you guys who do adult medicine know that. You know, they could have a lung issue, they could have pneumonia. You need to make sure that they don't have something else going on. You need to rule out anemia and thyroid and lungs and all the things that we always do. And if that's the case, you can't blame the symptoms on anything else. It's a class 1 indication to do a pulmonary valve replacement. The 2A indications here, there are a couple. So PVR is reasonable for preservation of ventricular size and function in asymptomatic patients. And primary prevention ICD therapy is reasonable in adults with Tetralogy, Fallot, and multiple risk factors. You'll notice that these risk factors look pretty similar to something I just showed you recently. But if you had inducible VT at an EP study, that also is considered a risk factor. The others listed here are considered 2B indications. So, as is the case with most of the guidelines that come out through AHA and ACC, they love the flowcharts, and frankly, I love them too. When I was a resident, flowcharts were wonderful for figuring out what I needed to do and say on rounds. And so if you see at the top here, it talks about Tetralogy Fallot patients with pulmonary regurgitation, and then the first question is do they have severely decreased ventricular function? Because if they do, they need to be seen by an CHD cardiologist and heart failure docs. If not, let's talk about the severity of the PR. If it's only mild, again, follow up with CHD cardiology, but if it's moderate or severe, then we start getting into the question about symptoms, which I told you one slide ago is a class 1 indication, and symptoms tend to be fatigue and shortness of breath. I see patients, or I have in my past, that will say they have chest pain. Tetralogy Fallot patients with chest pain saying that's an indication for a PVR. I personally don't believe that that counts as a symptom, as an indication for a PVR. Some people, though, can have edema. That's less common, abdominal edema or in their legs, even less commonly in their neck. Now, the bottom of the slide is a little hard to see, and so it says if you have 2 of the following, and so I made it a little bigger for you to see. So if you have any 2 of the following, mild or greater RV or LV dysfunction, B and C should be merged. This is using MRI or CT data for how big is the right ventricle. The end diastolic volume index is greater than 160, or the end systolic volume index is greater than 80. These count as a check, a point, towards an indication to do this. If the RV is twice as big as the LV, this also counts as a point, but you don't get an extra point for giving B or C. They really go together. If your RV pressure on a right heart cath is 2/3 systemic, then that counts as a point, as an indication to do a PVR, and progressive objective reduction in exercise capacity. This is as measured on a cardiopulmonary exercise test. CPETs are beloved in congenital heart disease, I believe, because they can give you an objective amount of information. The patients hate universally wearing, they have to have their noses clamped, and they have a little straw-like thing so they can get the oxygen and carbon dioxide and get it measured as they go in and out, but it gives objective information. So you have to have an objective decrease in your ability to perform exercise as an indication. Briefly, I'll put up one slide about ICDs for our crowd that are into those. So there are a lot of data about this, and I don't think that they're completely conclusive, but I'll put up a few key points. Is that there was a study done of Tetralogy Fallot patients who had ICD insertions, and they followed them up for 3.7 years, and they found that 30% of them had an appropriate shock rate. That's good. I mean, you want to have appropriate shock rates, right? You don't want to have inappropriate. But the problem is that about 1/3 of them also have inappropriate shocks, and about 1/3 of them didn't have one. And so I personally, if it was my child, and I said there's a 1 in 3 chance it's going to save your life, there's a 1 in 3 chance it's going to not do anything, it's just going to sit dormant, and a 1 in 3 chance that it's going to inappropriately defibrillate you, that would certainly make me think before I referred somebody for an ICD. The inappropriate shock rate is roughly 5 to 6% per year, and that there was another study that showed that unlike patients with heart failure or more traditional adult heart disease, patients with Tetralogy Fallot have an inducible sustained polymorphic VT, and that they fare as poorly or worse than those with inducible sustained monomorphic VT. The idea being that these patients, the point I'm making is that placing an ICD is often considered just an easy backup, or easy for us who don't put them in anyway, and you should just do it. There are guidelines that we use for adult medicine, and they just say you should do it. But in this patient population, you should be careful with patient selection. All right, I'm winding down here, so I'm going to go back to the case presentation, that young lady that I told you about before. And so indications for a pulmonary valve replacement for her could include symptoms. So if she is having shortness of breath and fatigue that can't be attributed to anything else, this would be an indication for a pulmonary valve replacement. If she had a reduction in exercise capacity on a cardiopulmonary exercise test. If she had a cath showing that her RV pressure was greater than 2/3 LV systolic pressure or systemic. If she had these MRI findings that I read out to you before, or if she had documented sustained VTAC, that's actually a 2B indication, not a 2A or a 1. So what if I modified what I told you from before and said that her RVF is in the upper 30s, her LVF is in the upper 40s, she still has the same valve function. Her RV is very enlarged at 175, and even in systole, it's 90, and she has a Holter monitor showing that she has 10 beats of VT. Do you guys think that she meets indication for a pulmonary valve replacement? Good. Yes, she does. She meets multiple of these factors, but she'd also qualify for a pre-op EP study with V-stim to see if you can induce arrhythmia. And she would be a candidate based on the criteria that we went over before, as well with her ventricular dysfunction, for an ICD insertion for primary prevention based on the new guidelines that just came out. So big picture here is that the wave is coming, right? The patients are here. I mean, I haven't been here this long, and I've been in Ginsburg, and they're here. And I think that it's up to us to be ready, not to be scared, but just to be ready for what is coming. And I'll say that I didn't write the guidelines, but I do benefit from them. They are what they are. They say that patients who have ACHD AP classification 1B through D, 2 or 3, so that's everybody who does not have 1A, should be managed in collaboration with an ACHD cardiologist. And so I am happy, and the other doctors here, we're happy to help manage patients with any and all of you. And I would say that, we can always be reached to answer a question about anything that might come up. And so whether they're having surgery, an intervention, a procedure, it's really important that it's done by somebody who has knowledge about congenital heart disease, because things can be just a little bit different as compared to the general population. The guidelines, again, published last month, cover a lot of topics that I'm not covering today. Among them include access to care, care delivery models, mental health, the mental health rate. There's 2 to 3 times the rate of depression and anxiety in patients who have congenital heart disease. It's something I think we should be aware of and looking for so that people can get help. Obviously, pregnancy is a big issue, and women's health, and we are lucky that we have all the resources here and the same structure to be able to collaborate with various physicians there, and even sports participation. I know in pediatric cardiology, we're seeing more and more patients for just participation in varsity level sports. But this also continues when you get older. It might not be sports, it might be doing physical jobs. A lot of our patients don't end up having wonderful jobs like we do. A lot of them end up working in stock houses and having to lift heavy things and do things like that, which is really potentially damaging for some of them. So the ACHA, which is the Adult Congenital Heart Association, it came up with these criteria in association with various accrediting committees on what is needed to be a comprehensive care center to care for these adult congenital heart patients. There's 19 things on the list, and I would just draw your attention to the fact that it isn't just you need a doctor. Like, that's just not how this works. You need nurses, you need nurse practitioners, you need to have interventionalists and electrophysiologists and surgeons here who are close by and ready to help and familiar with these things. Transition services, having reproductive services, psychology, social work, these things are all important. I think this goes with the Florida Hospital and the Advent Health mindset here too, that it's not just the body that you care for. And I think these guidelines are actually like the epitome of what we're trying to preach here, that you need to take care of the whole patient. And I think that we have all the resources here to be able to do that. So here in Florida, as I mentioned before, we have surgeons, EP, interventionalists, heart failure specialists, cross-sectional imaging, all the adjunctive services you could ever hope for, and it's in one spot. It's in one campus that's connected by a roof, so you don't have to walk outside through our horrible rainstorms. It's unique, and I think that we have everything we need to start going forward. And we're going to be applying for accreditation soon. That's part of why I'm here, is to make this happen. And I would like to conclude with that the ACHD population is growing rapidly. And we need to be aware of this and ready. Guidelines were just published, and the majority of ACHD patients require care with an ACHD cardiologist, or at least have me or us, our whole team, be involved in their care. And that they created this new system, the ACHD AP system, with the idea that we can categorize patients and maybe get prognostic information. Somebody could go from being a class C to a class A. If this young lady that I mentioned before, who was a class C, she was a 2C, because of her valve disease, underwent a pulmonary valve replacement, and she didn't have any significant valve disease, and she was still being as active as she claimed to be, she goes back and she's a 2A. And the beauty of this is that patients change. And we all know it, but it's always hard. As soon as you make somebody a New York Heart 3 or a 4, it's really hard to make them a 2 again. This allows you to move along the spectrum, and I think that's really important. And again, I think that caring for ACHD patients requires expertise beyond the heart. You have to sort of look at the whole person in order to care for them. Here's my contact information, and as a pediatrician, I have to put a picture of my daughter up in there. That's just, those are the rules. And here's my email and our office that you can always call, and we're always available. And so I'd like to say thank you to, I put our proceduralists on here, Dr. Trivedi, who does EP, Dr. Zussman, who does cath, and Drs. Pagula and Mavridis, who do surgery for us. But there are plenty more other members on teams, Drs. Nardell, Garcia, Ramos, Lee, and more. And I think that the whole team is growing, and it involves everybody in the room, you know, nurses, techs, doctors, everybody. And that's the way we're going to succeed. Thank you.